Muruganathan, sir?
Yeah.
We'll start, sir.
Yeah, we can start.
Yeah. Good evening. Good evening. I heartily welcome one and all for this World Diabetes Day virtual program. All delegates who have joined virtually from whichever place to learn from the esteemed faculty. On this occasion,
2 minutes, sir.
On this occasion, I welcome our guest of honor, Dr. P.S. Shankar, Professor Emeritus, RGHS Bangalore. I welcome Dr. Shivraj Alsetti, President MESAT, and Dr. Murugesh Pastapur, Chairman API and team. I welcome our guest of honor, Dr. Muruganathan, past Governor ACP India Chapter and Dean ACP, and past President National API, who needs no introduction. I welcome our guest of faculty and today's speaker, Dr. Nikhil Tandon, Padma Shri Awardee, Professor and HOD Endocrinology, AIIMS, Delhi. He is a Fellow of National Academy of Medical Science, BC Roy Awardee, a great teacher par excellence, researcher and a scientist with ongoing research going on in epidemiology of NCD, genetics of complex disorder. He leads technical coordinating with unit of youth onset diabetes registry with ICMR also, with many publications both national and internationally. I also welcome our other faculty, Professor Dr. A. Ramachandran from Chennai, President of IDRF, a great academician and a researcher, published more than 400 research papers with mobile technology of lifestyle modification and prevention of type 2 diabetes. He is a visiting professor of Imperial College of London, awarded Best Investigator Award by WIDF based in USA. Received many prestigious awards, delivered many orations, and headed the prestigious institute in Chennai, an internationally renowned academician, teacher, and a diabetologist of the country. I also welcome our today's panelist, our own faculty, Dr. R.J. Naik, who was kind enough to accept our invitation to join from New York, USA on Sunday morning. He is a chief endocrinologist at Westmont Medical Center, New York. He was clinical professor and a director of diabetes innovation at University of Washington, a great clinical researcher, has several peer-reviewed publications to his credit, and authored many chapters in textbook of diabetes. He has a vast clinical experience by working in India, Bombay, and USA. I also welcome our today's chief moderator, Dr. Bipin Sethi, chief endocrinologist from Hyderabad, a alumni of PJ Chandigarh, with vast clinical experience in diabetology in the country, with many publications, both national and international, a great academician and a teacher. On this occasion, I salute the COVID-19 healthcare workers for rendering their untired service to COVID-19 patients in spite of so many hurdles in the past, anticipating the third wave. Let us not waste the time by reading their CV profile, which runs in pages. Let us utilize time by hearing and exchange of knowledge with them in their respective specialty. As I can see, more than 100 delegates who have registered from many states making a national event. The advantage of virtual meeting, which COVID-19 pandemic has taught a new normal life, that speaks how powerful the speakers are there in their respective specialty. Now we have a formal virtual inauguration.
Shubham kurutvam kalyanam arogyam dhanasampada. Shubham kurutvam kalyanam arogyam dhanasampada. Shatru buddhi vinashaya Deepajyotir namostute. Deepajyotir namostute. Shubham kurutvam kalyanam arogyam dhanasampada.
We are virtually honoring all our guest faculty for their tremendous contribution to their work done in the respective field in the country. The citations and the medals will be delivered to their respective workplace. Request Dr. P.S. Shankar and Dr. A. Muruganathan to do the honors virtually. Request Dr. P.S. Shankar to address the gathering. Over to Dr. P.S. Shankar. Kindly unmute and speak.
Dr. Muruganathan, Dr. Tandon, Dr. Ramachandran, Dr. Bipin Shetty, my past student, Dr. Naik, Al Shetty, Dr. Biradar, Dr. Murugesh, colleagues and friends. We have assembled here to hear from the top authorities of India on diabetes. I am very happy the national and international faculty are taking part in this meet. World Diabetes Day was created in 1991 by the International Diabetes Federation and the World Health Organization in response to growing concerns about the escalating health threat posed by diabetes. World Diabetes Day became an official United Nations Day in 2007. It is marked every year on 14 November, the birthday of Sir Frederick Banting, who co-discovered insulin along with Charles Best in 1922. Since then, insulin has become an effective treatment against diabetes. The centenary of the discovery of the insulin presents a unique opportunity to bring about the meaningful change for more than 537 million people living with diabetes, a rise of 16%, that is 74 million since 2019, and the millions more are at risk. The day draws our attention to the urgent need to pursue multilateral efforts to promote and improve the human health and provide access to treatment and healthcare education. The theme for the current year is access to diabetes care. 100 years after the discovery of insulin, millions of people with diabetes around the world cannot access the care they need. Persons with diabetes require ongoing care and support to manage their condition and avoid complications. Medication, technologies, support, and care to be made available to all people with diabetes that requires them. Diabetes is a serious epidemic and lifestyle disease affecting millions over the world. 1 in 2 persons live with type 2 diabetes undiagnosed, and over 537 million people are affected by type 2 diabetes worldwide. The number is going to rise to 643 million by 2030 and 783 million by 2045. 1 in 12 adults, that is 7.4 crore people living in India are diabetics, according to the report of the International Diabetes Federation. 40 million adults in India have impaired glucose tolerance. More than 53% people are living with diabetes in India are undiagnosed. Type 1 diabetes is not preventable, but can be managed with insulin injections. The cost of daily monitoring, insulin injections, and ongoing treatments affects the finances of the families. The condition is causing emotional distress among people without access to diabetic education program. The aim of this day is to increase awareness of diabetes through campaigns. It raises awareness of the impact of diabetes on society, encouraging early diagnosis and support those affected. Though diabetes is not reversible on getting it, one can live with it without compromising on the quality of life. It also raises awareness on the ways to prevent diabetes and delay the onset with healthy diet and physical activity. It tries to prevent its complications, making them aware of the warning signs. The day gives an opportunity to get tips on food, exercise, and lifestyle. We are eager to hear talks on young onset diabetes, diabetes on inflammatory disease, and biomarkers, followed by panel discussion by the stalwarts. I am happy to associate with the inauguration of this program. Thank you.
Thank you, sir, for your kind words of wisdom. Now I request Dr. Muruganathan, sir, to address the gathering.
Thank you, Dr. Sangram Pradar, Dr. Shankar, Dr. Nikhil Tandon, Dr. Ramchandran, Murugesan, and all the dignitaries and faculty members. I am very happy and pleased to be there with you on a diabetic day, World Diabetic Day. One of the things which we must promote among the public is the awareness. See, every doctor, every physician, every diabetologist and endocrinologist has a moral responsibility to promote the awareness and screening of diabetic. And whenever I say diabetes, we should also screen hypertension, because diabetes is only 7 to 8 crores of people, whereas hypertension is 21 crore people are there. People die in diabetes because of hypertension and cardiovascular complication. So while we do screening for diabetes, we should also screen for hypertension. This is very relevant. I think my friend Ramachandran will agree. The Indian, especially South Asian, they have a very phenotype with lean. They are looking lean, but the abdominal obesity. This abdominal obesity, this metabolic syndrome, is the villain which produces a lot of unwanted cytochrome inflammatory markers. So before we screen the patient, we tell everyone that abdomen should be, for a male it is 90 centimeters, for female it is 80 centimeters. We all think about weight reduction. We must also make sure that abdominal obesity also should be reduced. And here we must create an awareness about what diet we should take. We should encourage the boys and girls and the youngsters to adapt the lifestyle modification even from childhood and college days. I think we should have a curriculum in the school and the college so that everybody knows what to eat and what not to eat. I'm very happy my friend Ramachandran involved these teachers, the school teachers and college teachers, in educating the students and public. I think that's the best way. And he was following with WhatsApp. There people are using WhatsApp and Facebook for various other reasons. I think it is very important. We use WhatsApp for following up and telling the people about the proper diet, high fiber diet, or what to avoid, trans fat, everything. So not only it is good for the public, but also we must sensitize the doctors to talk to the patients whenever they come. And while I say about home blood pressure, home blood sugar monitoring, you must also promote home blood pressure, blood sugar and blood pressure monitoring. And also you must not only weigh the patient, you must also measure the abdominal obesity and then advise properly, because diabetes will lead to so many complications. So we must defeat diabetes and prevent complications, and also must take care of our health. And in a routine checkup, everyone should undergo, especially type 1 diabetes. The children should be educated so that we can prevent their complications also. With this, I have great pleasure in handing over the medals and the certificates to all the awardees, especially my friend Ramachandran and Nikhil Tandon and other people. Now, once again, congratulate Dr. Sangram Bradar, Misat, and the whole medical academy for organizing such an interesting program on the Diabetes Day. Over to you, Sangram. Thank you very much.
Thank you, sir. Thank you for your words of wisdom. Now we move on to the scientific session. Now I request Dr. Nikhil Tandon to deliver his talk on young onset diabetes in India. Over to you, Dr. Nikhil Tandon, sir.
Thank you, sir. Before I start, I'll just try and get my slides on.
It's fine, sir.
You can see, sir?
Yeah. Fine.
Thank you. Very good evening, and it's an invitation from Dr. Bradar for several years. I must apologize that I have never made it to Gulbarga in person, but nonetheless, it's a pleasure to be with the community of physicians and in Gulbarga and North Karnataka virtually on this, for us, an increasingly auspicious day of the World Diabetes Day. So I will take my time to speak on an area which is a young onset diabetes in India. And by and large, the plan of my presentation will be a little bit about the epidemiology of youth onset diabetes. But then, as was mentioned in my introduction, I have an association with something called the Young Diabetes Registry, which is sponsored by the Indian Council of Medical Research. And a large part of what I will present will be results and data from the registry. So we'll talk about clinical profile, about complications, natural history, some efforts which we did to harmonize and compare with a US registry, which gives some interesting data, and of course, end up with a summary of events. So the first thing we must remember is, because we are a very large country with a lot of people, we are unfortunately on top of the list for the number of incident cases of type 1 diabetes overall and amongst children and adolescents. So it's very, very clearly a matter of concern. Obviously, in terms of the compared to certain other countries, as a proportion of the population, this may not be that high, but the numbers are clearly fairly high. We have limited data on the incidence of diabetes. As it happens, Professor Ramachandran is also, he was one of the first to actually present data on the incidence of type 1 diabetes in India. More recently, we've had the occasion, and this was what I mentioned in comparison or collaboration with the team from Search in the US, we've also looked at the incidence of youth onset diabetes by type, gender, and age. And let me just quickly run you through this. This was a bit of a complicated study because it required a method called capture recapture, in which we looked at different ways of accessing the same population using census data and trying to develop a denominator. As a result of that, we found that the incidence of type 1 diabetes amongst the Indian population was about 4 or 5-fold less than that reported in the US registry. And similarly, the type 2 diabetes incidence was also lower in youth. Now, I'd like to point out two caveats out here. Number one, that in an effort to harmonize our data with Search, we had to censor information to the age of 20 years because the Search registry was restricted to people with a diagnosis at or under the age of 20 years. And secondly, with specific reference to type 2 diabetes, what became important is that in the US, a large proportion of youth onset type 2 diabetes was seen in Indigenous Americans, Mexican Americans, and other minority populations. And actually the non-Hispanic whites were contributing to a much smaller extent to youth onset type 2 diabetes. Well, we'll go on to these comparisons a bit later, but let me tell you a bit about the background of the registry of youth onset diabetes in India and give you a little sense of what this registry has done till now and what is it doing. So the registry was set up by the Indian Council of Medical Research. Essentially, it started with a few cities in India. And the primary thing was that within a city, there used to be an entity called a collaborating center, either one or two collaborating centers, depending on the size of the city, which then reached out to what is called reporting centers. So let's take Delhi as an example. Delhi is being a largest city. We have two collaborating centers, one which is stationed at AIIMS and one which is positioned at the University College of Medical Sciences. So affiliated to the AIIMS Collaborating Center, there are 20, 25, maybe 30 reporting centers, which could be large corporate hospitals, which could be large government hospitals, or could be clinics, which are run by individuals with a special interest in youth onset diabetes, right? So the data is primarily collected from these reporting centers and brought to the regional collaborating center, where data is cleaned, quality control checks are performed, and then the data is sent to the National Technical Coordinating Unit, which for this particular registry is housed at AIIMS. So AIIMS Delhi has actually three hats in this process. We are a reporting center because we are where we see patients of young onset diabetes, and therefore we are primary data acquisition site. We're also the collaborating center for half of Delhi. And we are also the place where all the national data comes in for data management and data analysis. And after taking care of this aspect, we send it to the National Coordinating Center, which is housed at the ICMR for overall management and coordination. And therefore, the data which I should be sharing with you is the data which we received as a National Technical Coordinating Unit, and to some extent in a more restricted fashion also. So this is the registry at its present locations. From the north, we have the Sher-e-Kashmir Institute of Medical Sciences in Srinagar, PGI Chandigarh, as I mentioned, the two collaborating centers in Delhi, two collaborating centers in Mumbai. In a later phase of the registry, we had the Manipal Institute as a part of this, Chennai with the MDRF as a collaborating center, Cuttack as a collaborating center, and then two centers in the Northeast. One at the Assam Medical College in Dibrugarh, and more recently, the Regional Institute of Medical Sciences in Manipur. Please remember that the data is not restricted to these sites. The data for each one of these collaborating centers is then brought in maybe 20, 25, or 30 additional centers. So it's a reasonably representative data of that particular city. But I will underline the word city because this is not representative of the entire state. So it's metropolitan urban data, and I'll talk about that once again. Just to show you in comparison later on, since we harmonized the YDR registry, I'll call the Young Diabetes Registry of the ICMR as YDR from now on, with the Search registry, which works on a very similar principle. So it is in a few geographical locations. And the one particular difference is that in California, it includes all the participating clinics in what is called the Kaiser Permanente Southern California. Other than that, it works on very, very similar principles as the YDR and enabled us to harmonize data and contrast and compare. So what was the criteria for recruitment? All the cases of diabetes reporting on or after the 1st of January 2000 in a reporting center, so a designated reporting center, would be included provided they satisfy the following inclusion criteria. Their age at onset or diagnosis has to be less than 25 years, and they need to come from an assigned geographical area. So let's take AIIMS as an example. The study was actually initiated in 2006, but we had permission from the ICMR to go back in time up till the 1st of January 2000. And of course, it's still continuing. So it's an ambispective registry. Let's say a patient was living elsewhere in India, but came to Delhi for the first time in 2001. Even if they had their diagnosis before 2000, as long as they registered in a reporting center after the 1st of January 2000, they were eligible, as long as their age at diagnosis was less than 25 years, and they are now residents of the Delhi National Capital Region. So this is the sort of boundaries for recruitment in this particular study. As I mentioned, we started with retrospect on the 1st of January 2000, but the first phase ran from up till 2011. And then the second phase ran till 2019, and we've now entered the third phase in 2020. And what is really done is that when somebody comes and is registered in a reporting center, a baseline pro forma is filled. And then when the same patient follows up in that particular reporting center, in their first visit of a new calendar year, a follow-up pro forma is filled. For those whom we collected with retrospect, we had medical records. The other thing I'd like to point out is because of the complexity of the number of sites, the fact that some of the sites were not even large hospitals, there is no blood sample collection as part of this particular study. So it's a bloodless registry, but we have data to the blood work which the patients underwent in the individual clinics and or hospitals that they were a part of. What we've done is, again, because of an absence of blood work and a central lab, we looked at 8 categories of diabetes based on a clinical classification. I will not go into that. The first paper, which I showed you in one of the earlier slides, gives you a detail of the sort of clinical categorization. And for the rest of my talk, I shall restrict myself primarily to the first 2 sets of bars here, namely type 1 diabetes and type 2 diabetes. The first thing which you can see is that if you were diagnosed with diabetes under the age of 25 years in the participating cities, 1/4 were people with type 2 diabetes. And I keep saying this, and I'm sure people have heard me say this before and must be tired of it, but I would say that if I did my undergraduate examination, for that matter, in my postgraduate MD examination, if I saw a 20-year-old with diabetes and I put type 2 diabetes as a differential diagnosis, I would have been fairly significantly criticized, and I may have been invited back for a reappearance in the exam also, because type 2 diabetes, when we were under training, was, a 3rd decade, 4th decade, usually 4th decade or later. But now clearly you can see that if you are diagnosed within the first 25 years of life, there's a 1 in 4 chance that you will have type 2 diabetes. Clearly, that doesn't sort of take away from the fact that the single most common type of youth onset diabetes is type 1 diabetes. This is, again, to break it down a little bit more. If you take individuals who are with less than 10 years at the age of diagnosis, 96% of them have type 1 diabetes. So in the first decade, it is an overwhelming predominance, and there are the odd cases of type 2 diabetes. So if you even today diagnose somebody with type 2 diabetes in the first decade of life, you need to be very careful, and you have to have adequate supporting data because it's extremely, extremely rare. Really, the numbers of type 2 diabetes start rising in the second half of the second decade. And you can see the numbers have started coming out here, about 18% or so. But the big numbers really come in the first half of the third decade. So if you look, if you're diagnosed between 20 and 25 years of age, you're much more likely to have been diagnosed because of type 2 diabetes than type 1 diabetes. And that is a very important message which the registry gave us. And I think it's important for us as practicing clinicians to see and realize that. The mean age of diagnosis in the registry for type 1 was about 13 years, for type 2 was 21 years, and this becomes apparent from the data I've shown. The second thing which is important for us is, and I'll restrict myself to the top half of this slide, is to show that there was some degree of heterogeneity, right? Now, as you can see, most places, and these are the 11 collaborating centers, Srinagar, Chandigarh, 2 in Delhi, 2 in Mumbai, Manipal, Chennai, Cuttack, and then, of course, the 2 centers in the Northeast, i.e. Imphal and Dibrugarh. You'll see that most of the centers had between 70 and 85% of their recruited participants as type 1 diabetes. But if you remember from an earlier slide, that number was lower in the overall population, about 63% or 64%. And that is because 3 centers, number 1, Chennai, nearly 40% type 2 diabetes. Again, Assam Medical College, Dibrugarh, and the affiliated centers, again, 45% type 2 diabetes. And Manipur, again, 40% type 2 diabetes. So some degree of heterogeneity with certain sites having a significantly higher contribution of type 2 diabetes. Now, this could be because that's the way it's distributed within the population. This could be because of the institutions which are enrolled in this particular registry, but it's clearly an important point to see. And remember, if this is being observed in certain places, it is likely that in years to come, the numbers of type 2 will keep on increasing, and we'll have a virtual deluge of youth onset type 2 diabetes, which we have to take care of because of certain other data, which I'll share with you in a moment. Now, if you look at the mode of presentation, in people with type 1 diabetes, incidental findings were in about 1 out of every 7. Now, clearly, we expect type 2 diabetes to be more often asymptomatic or incidental, but unlike adult onset type 2 diabetes, you'll find that about 50% of youth onset type 2 diabetes had symptomatic disease, which included symptoms of hyperglycemia, osmotic symptoms, weight loss, even ketosis on the occasion. So clearly suggesting that type 2 diabetes in the young, as opposed to, in that which happens in the 4th, 5th, or 6th decades, is clearly a disease which is much more aggressive and much more symptomatic. The second thing, which is again not at all surprising, is the significant family history of diabetes in people with type 2 diabetes. About 45% with a paternal history of diabetes, about 43% with a maternal history, and 1 in every 4 having both parents with a history of diabetes, so it's conjugal diabetes. Right. This is again not surprising, and this is comparing the mean BMI stratified by diabetes type, and you can see that the numbers are very, very small in the first decade. So let's concentrate on the second decade, and you can see a clear difference in BMI of those diagnosed with type 2 diabetes and those with type 1 diabetes. Clearly, these are all adults, so you can make out that there were tendency towards overweight. But I will show you some more data a little later in this talk to clearly demonstrate that it is not essential to be overweight or obese to have youth onset type 2 diabetes, but clearly the difference was there between type 1 and type 2 diabetes. The other thing is that there is a significant presence of comorbidities even at the time of registration. So remember, somebody being registered today doesn't mean they were diagnosed today. As previously mentioned, they had to be diagnosed before they were the age of 25 years, and then they had to be registered in a reporting center on or after the year 2000. So I could have been registered in 2000, but may have had diabetes for the last 5 years, and being part of the study because I joined that reporting center for the first time, maybe because I came into that city for the first time. But still remember that there's a very small difference small gap between diagnosis and registration. And you'll find about 10%, as Dr. Muruganathan was saying, we must need to screen for hypertension, about 10% with hypertension, about 1 in 8 with dyslipidemia and other problems also. So clearly, even early in the course of disease after diagnosis, comorbidities which can impact on future macrovascular disease are already beginning to be present in youth onset type 2 diabetes. What about history of hospitalization in the year preceding the registration? So the baseline performer would always ask, were you hospitalized in the last 1 year? And you can see that there were basically the most important reasons for hospitalization in type 1 diabetes were severe symptomatic hyperglycemia, including DKA, and another 1 in 6 with hypoglycemia. So that's the constellation. Interestingly, even people with type 2 diabetes on or just before registration, and this word DK is used a bit loosely out here, it really means severe acute hyperglycemia necessitating hospitalization, was present in 1/3 of the patients. So really, if you look at adult onset or later onset type 2 diabetes, you don't get so many hospitalizations. But here, obviously, for the reason I mentioned, we are getting a sense that youth onset type 2 diabetes is an aggressive disease, more significant hyperglycemia, and perhaps a more rapid decline in beta cell function, and therefore acute severe hyperglycemia is more common as compared to peers who get type 2 diabetes later on in life. This is the third most important thing I'd like to point out in this particular talk, and that's the prevalence. And I will again talk about the incidence of microvascular complications at registration and then the overall burden. One thing which becomes very often very clear is that the prevalence of microvascular complications is clearly higher in type 2 diabetes compared to their peers with type 1 diabetes. So at registration, between 3 to 4% had diabetic retinopathy, neuropathy, or nephropathy if you had type 1, and about double the numbers had retinopathy or neuropathy if they were type 2, and a slightly higher proportion having nephropathy if they had type 2. So really, again, saying it is a symptomatic disease. It is an aggressive disease, very often showing symptomatic hyperglycemia and suggestions that there is a reduction in beta cell reserve. And thirdly, that microvascular complication risk in this population is high. And that is borne out, but this in the next 2 slides will essentially show with passage of time from the time of diagnosis. And if you go to more than 10 years, you can clearly see the gap between the prevalence of retinopathy between type 1 and type 2, significant, and the same in terms of neuropathy. But the difference was not marked in the case of nephropathy. Moving on to the clustering of CVD risk factors. So unlike microvascular complications, these are younger people. We didn't see CVD events or macrovascular disease events, but what we could look at was clustering of cardiovascular disease risk factors. We looked at smoking, alcohol, obesity, abdominal obesity, hypertension, and dyslipidemia. And once again, if you look at the blue bars, which reflect the clustering in type 1 diabetes, and compare it with the red bars, which is a clustering in type 2 diabetes, you'll see that people with type 2 diabetes more often have 2, 3, or 4 CVD risk factors, whereas those with type 1 diabetes more often have none, 1, or 2 risk factors, right? So you can see that about 15% of type 1 diabetes have 3 or 4 or more risk factors, whereas if you're looking at 3 or 4 or more, it's about 40% of those with type 2 diabetes. So clearly significantly elevated macrovascular disease risk, very much visible out there. I mentioned to you the likelihood of a lower beta cell reserve, the likelihood of aggressive disease in type 2 diabetes, the likelihood of early hospitalization because of acute severe hyperglycemia. And the other interesting point which comes up, and I'll just focus on that point, is if you look at the type of treatment being received, even those with type 2 diabetes had about 55% of them had already been started on insulin, either alone or in combination with oral hypoglycemic agents. Remember, these are people who are fairly soon after their diagnosis, and you will never see such a high insulin use in older patients with type 2 diabetes nearer the time of their diagnosis. So clearly another example or piece of evidence would suggest that beta cell function declines. And just as a little aside, if you go to the Today study, which had looked at intervention in youth onset type 2 diabetes using rosiglitazone, metformin, and lifestyle and combinations thereof, the rapidity of metformin failure and the rapidity of decline in beta cell reserve documented into today's study was far in excess of what was shown in comparable studies in older patients of type 2 diabetes, like those recruited in the study called ADOPT. Right. What about the regimen of insulin? Here, I would like to focus on type 1 diabetes and express my concern that we are not treating type 1 diabetes as aggressively as we should. I must point out that this was data captured at baseline. So this was prior to the time when they came to the sites where they were registered. So I may have been seen by a physician and then went to a diabetologist and endocrinologist. So this may reflect the treatment given to me by a physician who's not a diabetologist or endocrinologist, but it clearly means we must guide and educate and inform our colleagues in the community to be a bit more aggressive in the regimens they use for type 1 diabetes. As you can see, multiple subcutaneous insulin was used in 19 plus 14, that's about 33%. Everybody else was on once or twice daily. So predominantly 60% of type 1 before they reached a reporting center were on 2 doses of insulin, which is a matter of significant concern. And I think this is, again, a practice pattern which we need to flag and act upon. I'm now going to take you through some incidence data as regards complications. Now, we realize that getting a burden of complications or prevalence of complications across sectional study is enough. To get incident complications, we need to follow our patients as a cohort, and there are very limited data for incident complications. So what we really did was we took a bunch of patients who had let's say we were looking at retinopathy, had no retinopathy at baseline, and then followed them up over a period of time. Similarly, for patients with nephropathy, similarly for patients with neuropathy, right? So they were followed up either up till, so this was a 5-year follow-up. They were followed up till 31st of December 2014 from their start points. Either they were followed up till that date, or they were followed up till the date that they developed an event. And an event here means the presence of a newly diagnosed or newly incident retinopathy, nephropathy, or neuropathy. And I'm not going to go into detail with this, but the most important point I'd like to point out is this is data for retinopathy, neuropathy, and nephropathy. This is for type 1 disease. This is for type 2 diabetes. That for each microvascular complication, you can see not only was the prevalence higher in type 2 diabetes, but the incidence was also higher in type 1 diabetes. So about 3-fold higher incidence of retinopathy, about 5-fold higher incidence of neuropathy, and about 3-fold higher incidence of nephropathy. And if you look at any complication, it's about a 3-fold higher risk of incident microvascular complication in somebody with type 2 diabetes or youth onset type 2 diabetes as compared to youth onset type 1 diabetes. So again, it's a aggressive disease, youth onset type 2 diabetes. It is more likely to be symptomatic, more likely to require insulin, and more likely to have complications. I already showed you that there were higher risk factors for cardiovascular disease, so it means that they're most probably also going to end up with higher macrovascular events. So clearly it's a disease which is an aggressive disease, and it's a different disease compared to type 2 diabetes when it occurs for the first time in the 40s and 50s. This is again after adjustment for a range of covariates, including age, diagnosis, duration of disease, presence of any other microvascular complication at baseline, location, whether it was Delhi or Chennai, where the patient were taken, their BMI, the association with raised blood pressure, etc., etc., etc. But again, this is borne out that despite all these adjustments, about 2.5-fold higher risk of retinopathy, about 4-fold higher risk of neuropathy, and about a 2-fold higher risk of nephropathy, clearly reinforcing the point that this is a nasty, nasty disease. What we've been doing over a period of time, and this is, I just like to share this model, not because I think it's the best thing to do, but I think we've been very successful. The way we gather data on incident complications, remember, every one of us will tell our patients to undergo an annual complication screen, but every one of us realizes that our patients don't often get it. So we developed a CAMP model to increase the follow-up, and we developed it for the primary purpose of getting incident data. This has been going on till COVID interrupted it last year. It's called the Diabetes of Young Day at AIIMS. And what we do is one day in the year, we call all our patients of, and these are type 1 diabetes patients actually, primarily, and they are called in the morning in a fasting state. This is a large area. They come in, they have a registration. Once they're registered, they're asked to come fasting. They undergo a blood collection. We create cubicles where they can take insulin. We arrange for breakfast where they can go and have their breakfast. They come back after breakfast and their anthropometry is done, their urine is collected, they undergo a fundus examination, they undergo a monofilament test, they undergo some diabetes education, and then they go inside the auditorium for continued diabetes education. Then they can go back and have lunch, in which there are dietitians available to give them diet education, and they also can get lunch of 1400 calorie diabetes diet, 1600 calories diabetes diet, 1800 calories diabetes diet, etc., etc., etc. We started with a small number in 2014, 193 patients of type 1 diabetes, which is large. And you can see we peaked out with nearly 450 patients of type 1 diabetes, one day, one site. And remember, all of them came with at least one attendant. So we had about 900 people are there. You can see the numbers dropped in 2019, and I must tell you the reason for that. That was a day in Delhi when the minimum temperature was 1.6 degrees Celsius. One of the coldest days in the history of the city in 100 years. Despite that temperature, we had nearly 400 patients turn up. So much so the patients after the first year had started asking us, when are you going to do this scam? So these are patients primarily who are following up at the Young Diabetes Clinic with us at AIIMS, and we ask our colleagues in Safdarjung Hospital if they want to send somebody, but it's a large number for being collected at one site. In the process, we ended up harmonizing our registries with Search, and this is, as you know, the Search has contributed significantly to data for youth onset diabetes in the US, and I'll just give you a few slides to show the comparison. The first thing I'd like to point out is Search is from the age of 0 to 20 years. We are from the age of 0 to 25 years in the YDR, but we truncated our data till the age of 20 years so that we could compare it with Search. The first point, that even in type 2 diabetes, you can see that even in Search, about 20% of people were underweight or normal, but in the Young Diabetes Registry of India, 40% of youth onset type 2 diabetes were underweight or normal. It's an important point because in our mental picture, which a lot of us have, is that to be youth onset type 2 diabetes, you have to be obese because, you know, unless you're fat at that age, you're not likely to get this disease. But see this number, about 40% had youth onset, had either underweight or normal BMI. And the second thing was that we had terrible A1Cs, perhaps because what really was happening was that people were not coming to medical attention early enough, and this was a problem. The second thing, which is interesting, we really don't have an explanation for this, but this is real numbers, that when you compare YDR and Search, the trend in prevalence of DKA at onset is actually showing that there is a relatively constant number of or proportion of people with type 1 diabetes who are presenting with DKA at onset in YDR, but the number is rising in the US. Now, one unfortunate explanation could be that, you know, people die with DKA and so they don't reach medical attention, which could be a reason. But this is a very interesting piece of information. One would have expected that, you know, because of poorer access to healthcare, more people with type 1 diabetes will reach a level of diabetic ketoacidosis before they become diagnosed with type 1 diabetes in India compared to a high-income country, but that does not seem to be the case. The third thing which is important is the significant difference in insulin regimens between the US and India, right? So 16% on pump in the US, 1.5%, so a tenth of that in India. Basal bolus regimens, 65% in SEARCH, 23% in young diabetes, once or twice daily insulin regimens and 52%. So a matter of huge concern. These numbers are slightly different from what I showed earlier because that was the full YDR data. And this is the YDR information which has been truncated so that we can match the age group of SEARCH, right? And this is again only Delhi and Chennai data because that was the most complete data set that we had. And again, you can see that the high use of insulin is not seen only in India, but is also seen in SEARCH. So let me stop here and close out this session from me to say that I've been very fortunate to have been affiliated with the ICMR Young Diabetes Registry. This has enabled collection and collation of data from different regions of India. We recognize this is metropolitan Indian data. We recognize all the limitations, but today between phases 1 and 2, and we're still counting, we have information on 21,570 odd people with youth onset diabetes. And that's a very, very large number. I think to the best of my knowledge is perhaps the largest national registry of young onset diabetes. And I know several people who are in the audience have been critical as contributors, both in terms of patients and in terms of their intellectual contributions to this particular registry. There is a regional variation in the proportion of type 1 and type 2 diabetes. You saw that Chennai, Dibrugarh, and the Imphal clusters seem to have a difference, and we need to go to the bottom of that. Approximately 45% of all diabetes presenting between the ages of 20 and 25 years, or being diagnosed for the first time between 20 and 25 years of age, is type 2 diabetes. And that's a matter of concern, because remember, with the significantly aggressive nature of the disease, a higher burden of complications, by the time several of these people are 40, 45, we're looking at another pandemic, this time of diabetic vascular complications. Youth onset type 2 diabetes is more likely to be symptomatic. It has, as I mentioned, higher prevalence and incidence of microvascular complications. It also has a higher need for insulin. And again, that has implications because we keep saying, and as mentioned earlier today by Professor Shankar also, was that insulin is not affordable by a significant minority, but significant minority of people in this country because they have to pay out of pocket. Now, if that number is going to increase because of youth onset type 2 diabetes, we are going to be in serious difficulty. The other matter of concern, and I think this is somewhere that the diabetes endocrine community has to be more aggressive in spreading the word, is that there are suboptimal insulin regimens which are being used by the larger group of healthcare workers. And we managed to have some very interesting comparison with other ethnic populations as we picked up from the SEARCH registry. I'd like to stop here and thank you so much for giving me this opportunity to share with you some data which has come my way, not because I've collected it, but because I've collated it. Thank you so much once again.
Thank you, sir, for your excellent deliberation. Kindly stay connected. We will take questions into the panel discussion. Request all delegates to type the questions in the chat box. Now we move on to our second talk. Now I request Professor Dr. A. Ramachandran to deliver his talk on Is Diabetes an Inflammatory Disease? Very biomarkers tell the story. Over to you, sir. Sir, kindly unmute, sir. Kindly unmute and speak. Kindly unmute, sir. We are.
Yes. Well,
Yes,
thank you very much for the invitation, Dr. Sangram. And I'm very happy to be in the midst of a galaxy of eminent people like my friend Nikhil, Bipin, Dr. Ramchandran Naik, and my classmate, Dr. Muruganathan. and also the senior professor, Dr. Shankar. World Diabetes Day is being celebrated all over the world today, and we have so many functions going on today. Anyway, I'm happy to share with you some of our thoughts on this. I thought I'll talk on a new topic, and this is called is diabetes an inflammatory disease? Biomarkers tell the story. The reason why I'm talking about this is because biomarkers have been a hot topic in not only diabetes, cardiovascular disease, and in cancer. So I'm going to give you some evidence of this based on the work that we have done in our own laboratory. So this is only based on the work and it will be applicable to the Indian population. So to start with just some definitions, what is a biomarker? The NIH definition of a biomarker is it is a characteristic that is objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacological response to therapeutic intervention. So it's a very powerful tool. The FDA definition is any measurable diagnostic indicator that is used to assess the risk or presence of disease. In other words, biomarkers are not only predictive of diseases, but are also involved in the pathogenesis and therefore modifying them as a potential to change the course or onset of diseases such as diabetes, cancer, and cardiovascular disease. An ideal biomarker should refine identification of those at risk of a disease or progression, improve prediction of complications of disease, and or guide and help tailor responses to different therapy. So I think it's a very new area of research, and the interest in biomarkers actually came from the Framingham study. As you all know that we always think of conventional risk factors for cardiovascular disease, such as obesity, hypertension, diabetes, dyslipidemia, sedentary life habits. But this still do not explain fully the risk. And many people who do not have any of these conventional risk factors still develop cardiovascular events. So therefore, the biomarkers have become very important. To some extent, it can be explained that the biomarkers may be the thing that is telling us that there is inflammation going on, which is not being detected or which are not being detected earlier in our medical science. So what did the Framingham study show? It showed that the conventional risk factors do not fully explain cardiovascular risk. Biomarkers are new to identify persons who are at risk of cardiovascular disease. Biomarkers from multiple biologically distinct pathways are associated with the risk of death and major cardiovascular events. We already are using biomarkers in our routine practice. I'm sure all of you are familiar with C-reactive protein for inflammation, the natriuretic peptide for cardiac failure, fibrinogen, D-dimer, which we have been doing a lot because of the COVID, and homocysteine, etc. Now, there are many, what is the connection between biomarkers and diabetes? Because our work has been in diabetes. Biomarkers for diabetes should predict onset of diabetes in non-diabetic subjects. A very important statement. Biomarkers for complication should identify subjects with high risk of developing complications of diabetes, namely both cardiovascular disease or macrovascular disease, as well as microangiopathy. In some instances, a biomarker may be added to conventional risk variables to improve power of association or prediction. So biomarkers have added value, and you can add it to conventional risk factors in order to improve the predictive value. So now I'm going to turn to the diabetes world. Let us look at pre-diabetes, a population at risk of diabetes. The reason why I'm talking about pre-diabetes is because this is an intermediate state of hyperglycemia or before diabetes. In fact, we call it either impaired glucose tolerance or impaired fasting glucose, but lately, one of the discussions we had opinions saying that probably you should use the term intermediate state of hyperglycemia because it's intermediate between normal glucose tolerance and frank diabetes. Now, the point is pre-diabetes is detected by, of course, levels of hyperglycemia and HbA1c. You must know that pre-diabetes has not only had a high risk of diabetes, but also has high risk of cardiovascular disease. We know that hyperinsulinemia is a characteristic of pre-diabetes, but it is also known now that inflammatory states seem to exist in pre-diabetes. And that may be one of the reasons why they go and straight away develop cardiovascular events without even developing diabetes, frank diabetes. So the question is, can measurement of inflammatory adipokines or inflammatory biomarkers, some of the biomarkers are not adipokines, and I'll explain to you in a minute. Can measurement of inflammatory biomarkers be helpful to identify people at high risk of diabetes and cardiovascular disease? Now, the reason why it's important is because even if you diagnose pre-diabetes, some of them reverse to normal. In fact, not all of them will develop diabetes. There are many ways of conventional risk variables, and I will explain to you that. Now, only prospective follow-up cohort studies can answer the question. And luckily, we had prospective follow-up studies in pre-diabetes from our prevention trials. For those who are not familiar with the prevention studies I have done, I just put a couple of slides to show you that what we have done. Now, development of diabetes occurs from a normal state through pre-diabetes, and as I told you, it is an intermediate stage of diabetes. You have genetic factors as well as low birth weight, and the two important risk factors which can be identified by measurement in the laboratory are defective beta cell function by looking at the insulin values, as well as insulin resistance, the HOMA-IR and the HOMA-beta. Both can be assessed by doing the insulin values. However, not all people who have these abnormalities still develop diabetes or cardiovascular disease. Therefore, what we would like to do is that other added important risk variables, and they are called the biomarkers. They are pro-inflammatory cytokines or adipokines. Now, the adipokines or the pro-inflammatory biomarkers that we measured in our laboratory were adiponectin, retinol binding protein 4, GGT, which is a liver enzyme, and ALT also, alanine transferase, which is a liver enzyme, interleukin 6, leptin, bisfatin, and fituin A. These are the newer ones which have been described. Now, just for those who are not familiar with the prevention studies that we have done, the first study was called the Indian Diabetes Prevention Program 1, in which we took people with impaired glucose tolerance or pre-diabetes and randomized them into different intervention programs with a control population, lifestyle modification, metformin, and a combination of that, and the primary outcome was diabetes. And we found that the intervention did work because the cumulative incidence of diabetes was 55% in the control, while it was only 39 to 40% in the groups with intervention. So there was a relative risk reduction of 28.5, 26.4, and 28.2, which are all significant with the interventions. Now, this is actually published in 2006. And one of the first papers that we did was to look at the biomarkers. There is another second study called the SMS study, in which we actually used mobile telephone SMS for encouraging people to change their lifestyle to reduce incidence of type 2 diabetes in people with pre-diabetes. And this is actually published in Lancet in 2013. And we found, and this is the design of the study, what we did was we took people with high risk, and there is impaired glucose tolerance, and then randomized them into 1:1, and they were followed up for the next 2 years. The intervention group received text messages through the mobile phones 2 times a week, which was actually tailored messages. And the control group just had standard care that advised in the beginning and were seen at every 6 months. They were followed up for 2 years, and the results were pretty good. There was a 36% relative risk reduction in the incidence of diabetes in 2 years. Mind you, the first Indian diabetes prevention program I showed was done for 3 years, where there was almost a 30% relative risk reduction. This SMS study was done for 2 years, and there was still a 36% relative risk reduction. In fact, the absolute risk reduction was pretty impressive, 9%, and the number needed to treat was 11. What do you mean by this is that if you do intervention in 11 people within the trial period, we can avoid 1 diabetes, which is actually very cost-effective intervention in pre-diabetes to prevent diabetes. So as I told earlier, the prevention cohort gave us material and opportunity to look for biomarkers for diabetes. Very strange, and one of the first studies was actually published from our center. Dr. Snehallata was the first author. That was in 2003, and that was actually plasma adiponectin. Now, what is adiponectin? Adiponectin is a hormone produced solely by adipocytes in the body and is a regulator of glucose and energy homeostasis. Low adiponectin is associated with low insulin sensitivity and participates in etiopathogenesis of type 2 diabetes. Now, in order to see now, there are not, at that time in 2003, there were not many studies, only just 1 study on adiponectin, and we were the second in the world to publish the role of adiponectin in the pathogenesis of diabetes. And this was done in Asian Indian population. What you see here is the baseline tertiles of adiponectin, showing that those subjects who had lowest levels of adiponectin had the highest risk of diabetes, 12% for the third tertile compared to 56%. In other words, what is shown is that if you have low adiponectin, it shows high insulin resistance, or in other words, low insulin sensitivity, and then you have a higher risk of diabetes. And this is a follow-up study for 3 years. So we concluded from that study that low adiponectin concentration is an indicator of low insulin sensitivity and is a strong independent predictor of future development of diabetes in subjects with impaired glucose tolerance. Adiponectin may have a central role in the pathogenesis of type 2 diabetes. Mind you, this was published in 2003. The next biomarker was published in 2015 from the SMS study, and this was published by Ram Jagannathan, who's actually my PhD student. He finished his PhD from us, and now he's now working in United States. What is retinol binding protein? Retinol binding protein is a 21K delta protein and belongs to lipocalin family. Was initially known as a specific carrier for the delivery of retinol in circulation. It is secreted mainly by hepatocytes, 80%. In fact, it is not called an adipokine, actually it's called hepatokine, and adipose tissue only 20%. And this may contribute to systemic insulin resistance and therefore impaired glucose regulation. So we were one of the first to look at retinol binding protein in a global sense. And what you find here is the odds ratio of developing diabetes with higher and lower medians of retinol binding protein 4. And what you find is that the baseline serum retinol binding protein levels were independently associated with development of diabetes. First model after adjusting for GGT, triglyceride, BMI, and insulin resistance, and the second model further with HOMA-IR and GGT. So what you find here is that even after adjusting for conventional risk factors, the baseline retinol binding protein predicted diabetes 73%, almost 65 to 73% higher than those who had normal retinal binding protein. So this is another very powerful biomarker for diabetes. Recently, we published this study, which is published in 2014, and the first author is Dr. Nandita. All of us are aware of the fact that non-alcoholic fatty liver disease, or NASH, is seen more commonly in diabetes, and the relationship between or association between NASH or NAFLD and diabetes is very well known. But we have never seen whether development of NAFLD or fatty liver in a pre-diabetic state have a higher risk of diabetes. And that is what we did. What we did was we looked at the association of baseline GGT and alanine transferase with incident diabetes among men with impaired glucose tolerance. And as you can see here, as you can see in the model 1, you have higher median and a lower median. The GGT actually predicted diabetes twofold, and that is the hazard ratio for diabetes after adjusting for, again, age, body mass index, family history of diabetes, smoking. The model 2 was further adjusted for baseline tour plasma glucose, HbA1c, triglycerides, and even HOMA. In other words, what it shows is that even if you adjust for the conventional risk factors, such as high blood sugar, high insulin resistance, still the GGT levels gave a very high predictive value for incidence of diabetes. In other words, if you have pre-diabetes and if you have fatty liver disease, you have a higher risk of developing diabetes. So we concluded from the GGT was an independent predictor of incident diabetes. In fact, a combination of GGT and fasting plasma glucose offered a simple and sensitive tool to identify subjects with high risk of developing diabetes. This also confirms that hepatic tissue or liver plays a role in pathophysiology of diabetes. Whether correction of this metabolic abnormality could prevent onset of diabetes is an important question. So we may have to take people and then do another randomized controlled trials. This is a study published in 2015, where we again looked at adiponectin, but we also added leptin and interleukin-6. Now, I already told you about adiponectin, but interleukin-6 alters insulin signaling in hepatocytes and adipocytes and has got impaired energy regulation in the central nervous system. Leptin is also related to insulin resistance. And what we have found is that, as already you have explained, a lower adiponectin value, you can see this minus 5.9, predicted diabetes by 45%, but interleukin-6 also gave an odds ratio of 2.27. So these are adjusted for baseline age and family history of diabetes, body mass index, HbA1c, HOMA-ER, and the insulin index. So what you can see is there that both interleukin-6, which is an inflammatory marker, adiponectin, which is actually an insulin sensitivity marker, both predicted diabetes. In fact, if you sometimes combine the two, this is showing the sensitivity and specificity of using different variables. And if you combine iletin-6 and adiponectin, it gave a sensitivity of 73% and specificity of 65% to predict diabetes in those patients who have pre-diabetes. The last couple of minutes I'm going to spend on the latest study, which is actually published last month, October 2021. This is again done by my PhD student, Priscilla. And this is association of predictive value of very new biomarkers, adipokines and hepatokine, called bisfattin and fetuin. Now, just to make you understand what is bisfattin. Bisfattin is actually produced by the visceral adipose tissue. It's an adipokine from the central adiposity, adipose tissue from the visceral part, which is actually explaining why probably central adiposity can actually contribute to the risk of diabetes. The biological significance is regulated by hormones and cytokines influencing glucose homeostasis. Fetuin A is actually hepatokine. It is produced in the liver. And elevated levels are seen in obesity and even in type 2 diabetes and metabolic syndrome. Now, nobody knows whether it can actually predict diabetes, and that is what we have done. So what is shown here is the predictive value of, what is this actually, of bisfatine, which is actually an adipokine produced by the visceral adipose tissue. And you can see that in those who are third type, that is, if you have a higher baseline value of bisfatine, they had a 54% development of diabetes if compared to if you had low levels of bisfatine, which is only 12%. In other words, if you have high value of bisfatine, your risk is almost 4 times higher compared to those who have low value of bisfatine. Next, we are talking about the fetuvin A, and fetuvin A is a hepatokine. And what does it show? That if you have high values of fetuvin A, then again, you have almost 5-fold increased risk of getting diabetes compared to those who have low values. So both the hepatokines and the adipokine, which is secreted by the visceral adipose tissue, seem to actually predict diabetes. This shows you the sensitivity and specificity. The fetuvin A gave a sensitivity of 71% and 75% specificity, and bisfatine gave a sensitivity of 75% and specificity, which is pretty powerful predictive. Now, you may ask a question: if you combine bisfatine and fetuvin together, then you can look at the risk. The odds ratio bounces, spikes to 12 or 13. That is a 13-fold higher increase in your risk of diabetes if you have a hepatokine and an adipokine high levels with pre-diabetes. So incidence of diabetes higher when elevated levels were combined. Now, we also talked about metabolic syndrome. Now, and it is very interesting that we also not only looked at diabetes, we wanted to look at patients who develop metabolic syndrome, just not diabetes. And we found that both bisfatine and fetuvin, a hepatokine, as well as an adipokine, both even predicted metabolic syndrome in patients who had just pre-diabetes. So it actually shows that these inflammatory or pro-inflammatory adipokines are actually predicting not only diabetes, but also metabolic syndrome. In other words, they're also predicting high cardiovascular risk. So the study compared association, and then now we looked at and searched in the literature to see whether there are any other studies where they have looked at diabetes and the predictive value of the adipokines that we did. And we looked at this study. This was the DPP, or the Diabetes Prevention Program, done in the United States. And they did what is called the non-traditional biomarkers. The study compared the association of circulating biomarkers of inflammation, endothelial and adipose dysfunction, and coagulation. And they found 2 of them. One is adiponectin, which we found, and that is correct. And they found another one called E-selectin. E-selectin is a very important. This is actually produced by endothelial cells, and actually high value shows endothelial dysfunction. It actually predicts diabetes in this particular study, but it is also been associated with incidence of cancer. So look at this. Inflammatory markers seems to be related to diabetes, cancer, and even cardiovascular events. And they also found tissue plasminogen activity. The last study which I'm going to show you is a study from Germany, in which a very large population was followed up, and they looked at type 2 diabetes. They also looked at cardiovascular disease, and they found that they have the same biomarkers: E-lectin, adiponectin, HDL cholesterol. All of them were actually predicting cardiovascular events, type 2 diabetes, and even death. So to conclude my talk, the high levels of pro-inflammatory cytokines or biomarkers in those who develop diabetes indicate that they have a role in the pathogenesis of diabetes. Therefore, diabetes is an inflammatory disease, and that is the question I asked in my title. In fact, that is why people with diabetes, or some of them, even without conventional risk factors, develop complications. And we are not able to know who are the people who develop diabetes. Perhaps these inflammatory markers will identify people with high risk of complications. And the association of some of these biomarkers with cardiovascular disease probably indicate they have a role to play in the development of complications. So the future success of biomarker strategies may depend on the discovery of new biomarkers to complement the best existing ones, perhaps with the help of new unbiased approaches. Now, all the FDA approved trials, clinical trials for diabetes, cardiovascular disease, cancer have mandated that biomarkers should be added to their investigations to see whether the biomarkers have a role in these diseases or the development of these diseases. I'd like to thank my research team, the clinical team, and my collaborators, Jaakko Terminator from Helsinki, Wes Johnston from Imperial College London, and Nick Wareham from Cambridge. Thank you.
Thank you, sir, for your excellent deliberation. Now we move on to the panel discussion. I request Dr. Bipin Shetty to take over the podium. I request Dr. Nayak also to join.
Yep, I may have to leave absolutely at 8 o'clock because another one is at 8:15.
Okay, we will then try
problem.
to ask you the questions that are there, and I hope Nikhil can stay back for another 15 minutes.
Sure, I will.
Okay, so I think it's nice that both the speakers, as professional as they are, not only delivered scientific talks but also stuck to time. I will first take Dr. Nayak's comments on, as I said, Dr. Ramchandran's talk, and then I'll pose him some questions. I'm looking at the chat box but not finding any questions. Then I request viewers to post some questions to him. Dr. Nayak's comments, please.
Yeah, I don't know, Dr. Ramchandran, do you wanted to take your questions first before you leave, or you are okay?
I'll be thankful. Sure.
Yeah, I think, Bipin, probably maybe ask people if you have any questions for Dr.
I'm waiting for the questions. We've requested them to post them. But meanwhile, since he has to leave, we might as well use this time.
Yeah, I think both were, my comments, we heard two outstanding talks from two outstanding people. So there is no specific things to add. The only thing from the US perspective, what I wanted to highlight was that in the young onset diabetes that we see here, there has been, obviously there are a lot of type 2s we are seeing, especially in the multi-ethnic population of African American, Hispanics, with lot of type 2s in the young onset diabetes below 25. But there is another variant which has always been always under debate, has been ketosis prone diabetes in the adults, ketosis prone diabetes, because these young people present phenotypically like type 2 diabetes, but they present with ketoacidosis. The question comes, is this ketoacidosis part of a superimposed type 1 autoimmune disease pathophysiology with type 2 diabetes versus it is clearly a type 2? So that brought the new topic in 1990s, which called ketosis prone diabetes in young, which actually was also called atypical diabetes or flatbush diabetes because it was identified in one of the areas in New York region. But then currently there are multiple classifications, ADA classification, modified ADA, depending on presence or absence of autoantibody profile and the beta cell reserve C-peptide. So the bottom line is that if we identify someone young who is ketosis prone, knowing their autoantibody profile and their C-peptide reserve would help decide if this unprovoked ketoacidosis episode requires something of a short-term insulin therapy. Later they can do well with oral drugs as if in a type 2, versus those who have absence endogenous reserve, irrespective of what that autoantibody profile shows, which sometimes in ADA classification they call as type 1B, require a longer term insulin. Just as a corollary, on this Friday morning, I happened to see two patients, young 21 and 22 year. One of them was a common garden variety of type 1, diagnosed at 9 years, strong family history of type 1 in sister and father, multiple dose insulin, uncontrolled ketoacidosis episodes due to missing insulin. 22-year-old African American obese person admitted recently with ketoacidosis, again with 400 glucose A1C of 13-14, on insulin, treated for 4 years as type 2, but he had 3 episodes. So this is the one I was referring to, who might actually fit into the category of ketosis prone diabetes. So this is just a comment that I wanted to make with respect to Dr. Tandon's talk. And the other component, which has been my passion, which I think maybe we can talk in some other meeting, was latent autoimmune diabetes in adults. We are talking about young onset type 2 diabetes. And now on the other end of the spectrum, we have people who are more than 25, 30, 35 who present phenotypically as type 2. But if you look at their autoantibody profile and beta cell functions and T cell reactivity, they have markers of type 1. So that's what we call LADA, or slowly progressive type 1. That's another end of the spectrum. So we have significant percentage, I'm sure everywhere it's common, like 20 to 30% phenotypic type 2s presenting with autoantibody positivity, and it has its own implication in terms of treatment decisions. So that's the high level comment on that, and nothing more to add really beyond that.
Thank you. Any comments on Dr. Ramchandran's talk?
No, I think it is opening up a new area of what he was referring to as basically hepatokine and adipokine and other biomarkers, using them to predict the risk of type 2 diabetes and also metabolic syndrome. This is absolutely an innovative space, and it shows where the field of inflammatory biomarkers in type 2 diabetes and metabolic syndrome, and in turn prediction of cardiovascular risk, is moving. So it was actually a new learning for me as well, what he spoke. Nothing more to add.
Thank you. There is a question which says that, how do you prove an association versus causation? And second thing is that, do you feel that addressing this, because there is a lot of story about CRP being associated with bad outcomes, but changing these markers, does it actually reduce the risk in specific instances, C-reactive protein and also homocysteine? Dr. Ramchandran, please.
Yeah. I think that's a question I asked when I was putting in the conclusion that the FDA has now mandated that all clinical trials, especially diabetes, cardiovascular disease, and cancer, where biomarkers have to be added to there. You have to take baseline biomarkers. The reason being exactly the question that he asked. Now, there is association as well as you're talking about causation. It can be only sorted out if you have follow-up studies, and that is what we have, fortunately, because when you have higher levels, then the patient is not having diabetes, there is no association, and then the higher values make you prone for diabetes, and you develop diabetes independent of other risk factors, and therefore it is not just association, it is actually a causative factor. Now, how it is being caused, we have to go back to the experiments. However, we know that if you have high values at baseline without the disease, and then they develop the disease, that is not association, that is actually causative association. That's what. So prospective studies will actually do. Now, there are many inflammatory markers which are actually common. For example, you have pro-inflammatory markers which are common both for cardiovascular disease as well as for diabetes and even for cancer. However, the most important point that you have to understand is that even in diabetes, which is a very common disease, we do not have explanations that while some people develop diabetes complications, some people do not develop. In spite of the fact, you try to explain it with other risk factors such as dyslipidemia and hypertension. Perhaps in diabetes, these inflammatory markers are telling you that diabetes actually starts as an inflammatory disease and makes you a diabetic. And then if you continue to have those markers, you have a higher risk of cardiovascular disease. Perhaps you also have higher risk of cancer compared to the normal population.
There is a comment from Dr. Praveen from Hyderabad. He says that now there are additional inputs for causation of diabetes, and in the aggregates level, we have inflammation also included after defranzo. What are your comments about the COVID-associated inflammation and causation of new diabetes?
Oh yeah, that's a good question. I was a part of a letter wrote to the New England Journal of Medicine. In fact, this has been a hot topic, and we have been doing a registry on this. You know that COVID is a new virus, and you know that viruses can actually go and attach to the beta cells and kill them. Now, one of the mechanisms could be that some of them are actually because the virus is actually producing something like type 1 diabetes, and patients who never had history of diabetes develop autoimmune disease. The other one is there are many people who are pre-diabetic and also have susceptibility to diabetes. So when they get an infection, they develop diabetes. Added to that, in COVID, you also give steroids. So many pre-diabetics who gets COVID develop diabetes because of infection as well as steroids. But there is another category where you find that actually they are producing pure autoimmune type 1 type of diabetes due to COVID infection. And that is a very new entity.
And what about the inflammatory cytokines that were associated with this? Do you think that also resulted in worsening of insulin resistance, just apart from the insulin deficiency that you alluded to?
Of course. Now, I talked about inflammatory markers. I also talked about adipokines, which actually indicate insulin resistance. Now, not all adipokines are pro-inflammatory. Some of them are pro-inflammatory, but some of them are actually associated more with insulin resistance. For example, adiponectin is a good example. Adiponectin is not an actually inflammatory marker. It is actually a clear-cut marker of insulin resistance. So if you have a low adiponectin value, you have high insulin resistance. So adiponectin is a good one, and that is what we have found. So that is actually a very pure adipokine, which is actually indicating diabetes. On the other hand, the fetuin A and other things which are liver markers, we do not know, because there are not many studies. Ours is one of the first global study on some of these biomarkers. And mind you, you are getting new biomarkers coming almost every month or every 2-3 months coming out, and the associations are getting, and also predictive value are being done in number of populations. Associations are very easy to do because they are cross-sectional studies, but all the clinical trials in the United States now are mandated to do biomarkers in order to see the causations and then answer the question where modifying the biomarkers can prevent the disease.
Thank you. I'm aware that you have just 2 minutes to go. So I thank you. You alluded to the fact that these could be markers of insulin resistance. They could predict the onset of diabetes. A constellation of these biomarkers indicate the greater possibility and likelihood, as also these are markers for CVD. So even though they may not be done routinely, at least in people who are having their high risk for disease because of family history or something else, maybe we can aggressively tackle the conventional risk factors, and that might be a pointer to better care. Is that what you want to suggest?
Absolutely. You know, all these things come after doing research. When you do research, all of them are new, and most of these are very expensive to do. But as it becomes a research knowledge, it becomes an information, and then what happens is people start producing more of these ELISA kits, and then you have more confidence that these are measurements which can actually predict diseases, and then it becomes a routine. For example, many years ago, we were not doing D-dimer, we were not doing C-reactive protein, we were not doing many of the markers we are doing right now. Even that natriuretic hormone we are not doing. All of them came after all these randomized control trials where they found that these hormones and these adipokines or these biomarkers are related to the development of diseases. So right now, what I've talked to you is in the research stage, and more studies will come out. And very soon, after, of course, from research to clinical practice, now the time is very short because people, you know, the transformation is faster now than what it was a few years ago.
Thank you. Thank you. I understand that you have, it's just 8 o'clock, and thank you very much. Now we also have some questions to Dr. Nikhil, who's been waiting patiently.
Thank you, Sangram. Yeah, thank you.
Thank you.
Bye.
Dr. Nikhil, there is a question for you, which is 2 questions. Why don't we measure insulin levels, and when is a good time to do C-peptide?
So let me answer this question in the context of the youth onset diabetes sort of talk that I gave. As Dr. Nayak actually already mentioned, what is being strongly advocated and hopefully will make a transition from research to clinical practice in several parts of the world is that if you see a person with youth onset diabetes, you use two sets of diagnostic assistance. One is the presence of antibodies, GAD65 and IA2 being the two prominent ones, and then a measured fasting C-peptide. So if you look at the search data, they categorize people into four groups: autoimmune plus insulin sensitive, autoimmune plus insulin resistant, non-autoimmune plus insulin sensitive, non-autoimmune plus insulin resistant, right? And the insulin sensitivity and resistance were using a formula which they had validated against the hyperinsulinic euglycemic clamp, right? Now, the first and the fourth categories are classical type 1 and classical type 2, right? Autoimmune plus insulin sensitive type 1 or non-autoimmune plus insulin resistant classical type 2. The second category of autoimmune plus insulin resistant is actually raising that important point, which Dr. Nayak also mentioned, is there a concurrence of type 1 diabetes with obesity? And we're all seeing that in our clinical practice because of background increase in obesity, or is it, a variance of the sort which were mentioned? 10% came in category 3, which was non-autoimmune and insulin resistant. Could they be MODY? Could they be autoimmune without the standard autoimmune parameters? So that's how it is. But if you look at fasting C-peptide in the context of these categories, you'll find that a large proportion, there are two poles: much lower fasting C-peptides in the classical type 1 with insulin sensitivity and much higher there. But if you take an arbitrary cutoff of 0.4 for fasting C-peptide, about 40 or 50% of people with the autoimmune variants will be less than that, whereas only 10%, 12% of those who have type 2 will be below that. So it is useful. The only problem with using fasting C-peptide early in the course of disease is that, with the persistent hyperglycemia at that point in time, you may get an erroneously suppressed fasting C-peptide because of, as we know, glucotoxicity. So it may be something which you keep in your pocket after controlling sugars. Going back to the classification, I just wanted to sort of add on to a comment made by Dr. Nayak. I was part of the WHO committee, which sort of has looked at the reclassification from a WHO purpose. And I think what we tried to bring back into that classification was one important thing, which I strongly believe in. And I'm sure you, Bipin, will also believe in that. When a patient of diabetes comes into my clinic, the most important question for me by the time he or she is leaving is, especially in a younger patient, is, do I send this person on insulin or do I not send this person on insulin? Very broadly speaking, you can err on the side of giving insulin in the beginning because you won't cause irreversible harm. But if you err on the side of not giving insulin to somebody who you should have given insulin, the implications and consequences can be very, very significant. And therefore, that has to be the paradigm. It also raises the issue that there is this diabetes in that individual is not going to go away, right? So there is no urgency that you have to stick a diagnostic label on them the very first time that you see that patient. It's open for discussion. It can happen 3 months down the line, 6 months down the line. And as Dr. Nayak said, there's several patients who the Flatbush variants presented with DKA, but several of them went on later to be managed even without insulin over a period of time. So this is an important message I'd like to give trainees, that there is no obsession about giving a diagnostic label. We have the luxury of time, as long as you don't make an erroneous clinical decision at that time in terms of what treatment needs to be given to that individual.
I think that's very important. So if we can use the terminology, whenever you are in doubt, err on the side of insulin, because you can always take it off if it is not required. But don't send someone whom you have even an iota of suspicion that this patient could be type 1 diabetic, and then the follow-ups being what they are. You will feel very bad afterwards, whatever happens to the patient. I have another theoretical question, Nikhil. When Sanjeevi published some papers back I think 10, 20 years ago in Stockholm, he highlighted the issue of LADA. And we all felt very guilty that we are denying insulin to such people, but routine follow-up of many of these patients, they are on insulin anyway. There has been another paper which talks about the benefit of drugs like SGLT2 inhibitors and DPP4 inhibitors being denied to these patients just because they're antibody positive. What is your stand on that? So it looks like C-peptide is no good. Antibodies could also be either way. So if you have an antibody positive person, you are sure that this person over a period of time might require insulin more often than not. And this might actually be entertain the diagnosis of diabetes that everybody knows. But must and should every patient of so-called NADA be pushed on to insulin even when they are controlled very well with conventional agents?
I think let's put the work which you alluded to in the context of the time of life when it was done. I think we had two medicines to give, sulfonylurea and metformin, right? From then on, I think the spectrum of medicines available to us has increased quite significantly. I would actually sort of tend to go by what you say, as long as, and this is the importance of as long as, and you already also alluded to the fact that our follow-ups are not perhaps as good as desirable, right? So if you're assured of, assured is perhaps a very strong word, but if you've discussed something with the patient, told him or her that given your clinical and autoimmune profile, there is a likelihood of you requiring insulin in the not too distant future. However, we are willing to continue on oral medication with the proviso that A, you follow up on a regular basis, B, you even follow up earlier than that if you suddenly find an alarming jump in sugars. I see no harm at all in giving these people continued oral anti-hyperglycemic agents. But those provisos have to be, and I would be a little wary of doing it in a person who's come to me for the first time in the OPD. I have no rapport with that individual. I don't know whether they will come on a regular basis. But if the person has come a couple of times, I've had a chance to talk to them, gauge what is their ability to understand what we're saying, I would actually say that, if you're giving a person 2 less years of insulin, what's the harm?
Yes, yeah. Dr. Naik, one question. See, nowadays, everybody is talking about inflammation and the drugs having anti-inflammatory property. There were trials with salicylic acid, etc., which didn't show any benefit. But now they say GLP-1 analogs, the MRA agonists, which are there, specifically finerenone, SGLT2 inhibitor, they are modulating the disease process through inflammation and fibrosis. Do you think that we are heading towards some kind of addressing the inflammation through these agents?
It's a difficult question. I think eventually we might there, but right now I would say the practice is still revolving around the typical guidelines laid down by the cardiovascular risk reduction and presence or absence of heart failure and renal dysfunction, especially coming to the SGLT2s and the GLP-1 receptor. I agree that one of the pathophysiologic mechanism by which these drugs work and produce their benefits beyond glycemic control is through inflammatory pathway reduction. But at the same time, I think it's too early to say that inflammation as a yardstick in determining what kind of therapy that we should be using. It's still very much based upon the cardiovascular and renal risk and heart failure. What we have all seen in the last few years has been that tremendous surge of these SGLT2 inhibitors and of course GLP-1 receptor agonist as well. The whole mental perception has changed. I remember very clearly in 2012 when I was at Merck Research Labs working in diabetes drug development, and Barry Goldstein and I were talking once. He was the head of cardiovascular. He was a former professor at Thomas Jefferson. We kind of said, what is this SGLT2? You are making the person lose glucose in the urine and that to treat diabetes. It sounded a stupid idea. At that time, dapagliflozin was, and we went and attended to the FDA's meeting for dapagliflozin approval. First time it got rejected, I think bladder cancer risk or whatever, then it came back again. So from there, few years ago in Syracuse, one of the medical reps were asking from Boehringer that, do you think the cardiologist will start using? I said, no. Why would cardiologists use it? It's a diabetes drug. We use SGLT2s more often and they will follow nephrologists. But come today, SGLT2s are prescribed more by cardiologists and nephrologists, and their nephrologists are prescribing with a GFR of 22, 25, and cardiologists are prescribing Farxiga, dapagliflozin pretty much with, now it's a standalone approval with heart failure with preserved ejection fraction as a standalone without diabetes. So with all those things, we never know how this inflammatory biomarker driven or inflammation reduction related endpoints being used in treatment of diabetes. Anything is possible. The way the whole thing has evolved in the last decade, it's totally unexpected in 2011 that we would be using SGLT2s for people without diabetes. So
another question and comment to Dr. Nikhil. See, we are used to diagnose diabetes very simply by glycemic parameters, that is glucose and HbA1c. Now, it appears that we need to, in certain special situations, also see the beta cell function, not in all, also the autoimmunity. Until late, ADA and ESD had no guidelines on treating or diagnosing diabetes in the young. Now they have also realized, and recently in a month ago, they have come up with the guideline that look at a patient, if the patient is ketosis prone, you treat him, stabilize him, and then try to see the C-peptide levels. And if you find them okay, then it's fine. Otherwise, you treat them differently. How do you think this thing has evolved, and why is it evolving? Is it because of greater incidence of type 2 and other diabetics in younger children, which we used to think are always type 1? You have to unmute, Nikhil.
I think what is happening is registries have started coming up with data and numbers which previously, you didn't have them in a consolidated way for us to analyze carefully. Whether it's search, whether it's suite, they are just consolidations of very large numbers. I must give you a little story, which is not answering your question, but I still remember there was a workshop which the WHO in India had done with the ICMR, which was about diabetes, which led to the creation of this Young Diabetes Registry. I was, attending that, and I must tell you that this meeting happened in 2001 December, and the basic idea for pushing a registry at that time was to get information about type 1 diabetes. The fact that we'll be collecting information on type 2 diabetes in that age group had not entered our mind, had just not entered our mind, right? And now today I'm presenting to you data that if you are looking at, 100 people with youth onset diabetes under the age of 25 years, 25 of those have type 2 diabetes. It was not even part of our consciousness at that point in time. So it's realizing, and I think it's also realizing, you see, when we found a high prevalence of complications in YDR and the high incidence, the first thing which happens is when you're doing something new is you feel insecure. I mean, have you made a mistake? Have you erred somewhere? It looked bizarre that, type 2 diabetes should have a much higher prevalence of microvascular complications. And then the JAMA paper from Search came out, which showed very clearly. And then you said, okay, thank God there's somebody else who's also seeing something similar. That, if two people making a mistake is less likely than, us making the mistake on our own. So I think data are coming up, which is showing that this looks to be, and using a English turn of phrase, that young onset type 2 diabetes is a totally different beast compared to, the sort of type 2 diabetes we saw when we were, in trading 40s, 50-year-olds, gradually plundering along. This is dangerous disease. And I think it's important. And very often when you have a disease in which you can, say, okay, give some tablets, people don't take it seriously. People look after your type 1s more clearly because it is catastrophic if you don't give insulin there. Here, they'll have uncontrolled hyperglycemia, they may be symptomatic, but they don't realize that they are at the verge of a disaster. So I think it's become important to identify this group and focus on it differently from type 1. And I think that is, again, going to be important. And as they grow older, instead of just metformin as an approved entity, once they cross into adulthood, very clearly they can be given all sorts of other medication and helped out. But I think it's just relatively new information in that sense.
One question has come up, though it's not related to either of the talks, is the influence of anemia on HbA1c.
So again, it really depends on whether it's a low turnover or a high turnover state, you know. So if you have iron deficiency anemia, you can have things going in one direction. If you then treat that person with iron, you suddenly become a high turnover state, it goes in the other direction. In India, it's a very pertinent question for India because of the fairly high prevalence. And therefore, if you look at a lot of epi studies, they've started saying that you need to adjust it for ferritin, which for me is, you know, it's
Even more difficult.
It's very difficult, yeah.
Even more difficult to do. But let me also share a very interesting opposite report. So there's a friend and colleague from Peru called Jaime Miranda, and Peru has a lot of places at high altitude. And the impact of polycythemia on hemoglobin A1C was dramatic, was absolutely dramatic. So you have to look out. But I think, you know, in the general 10, 11, 12 gram hemoglobin, I think we should be okay. I think it's that, you know, when you dip to the 7s and 8s that things start getting messy.
Yeah, some people use here fructosamine, but I'm not a big fan of fructosamine either. I mean, it just doesn't add value. It go by blood glucose values rather than anything else. If in the range of below 8 hemoglobin.
I think, yeah. So any one-line comments from you? Because I think Dr. Sangram is looking at me very angrily. It's 8:15.
Yeah, no problem. Since there are no much questions, because both the talks were so crystal clear, questions have not raised from the audience. So we can have a comment, take-home message from each.
Yes, so to start with Dr. Naik and then Dr. Nikhil.
Yes, sir, yes, no problem.
So
Dr. Naik,
take-home message, I would. Yeah, I think diabetes, whether it is India or the US, is increasing, whether it is type 1 incidence, which is actually quite scary and concerning, incidence going up, and also recognition of type 2 diabetes pathophysiology in the younger individuals, I think is an important thing to keep in mind. And as Dr. Tandon and we have been discussing all through, understanding their underlying pathophysiology of autoimmunity versus beta cell function will determine the long-term management of these people. And regarding, I think Dr. Ramchandran, the message I got was it shows an exploding space of biomarkers. And as he rightly said, which I clearly recollect from having worked in the industry, biomarker strategy has become part of drug development of any diabetes space. And more biomarkers are being used in terms of predicting the disease. And I think the field is definitely heading in a very rapid pace in this direction. I think that's my take-home message. I would leave it to Nikhil to provide his comments.
Yeah, Nikhil.
So from my side, I think there are just 3 or 4 small issues. One is, I think our ability to have our antennae up to recognize people before they go into an acute severe hyperglycemic state. So you don't have, you know, these younger people ending up in the emergency rooms. The second thing is, I think the responsibility lies on the community of diabetologists, endocrinologists to spread a little bit more. There's no way we can treat everybody. I mean, you need internists, you need a whole group of people to treat, is to understand that especially for type 1 diabetes, you know, twice daily premix regimens are perhaps doing a disservice to the patient than anything else. And we need to strengthen the hands of our colleagues who are, you know, also involved in the treatment of type 1 diabetes, explain the role of self-monitoring of blood glucose and the ability to understand patterns from there so that appropriate changes can be made. The third thing is not to disregard youth onset type 2 diabetes ki, as they say in Hindi, they'd say, oh, goli wali dawai hai. You know, it's like you just give a tablet and you're fine, which is being dismissive in some ways, right? It doesn't even need an injection. But the problem is it appears to be a very, very dangerous disease. And I think we've got to be careful. And my plea is, I think, especially for the trainees and younger colleagues, is that as Dr. Ramachandran said, a lot of things started from, being inquisitive, looking at things. Research sounds very grand, but all we're saying is, keep your eyes and ears open. If you see something which is interesting, that can eventually lead on to the next significant change and even a standard clinical practice recommendation. So, it's just being open-minded, think of what you're seeing, and then proceed from there on. I mean, you don't have to have some sort of certificate to say that you're a researcher. Basically, all we're saying is, be inquisitive and curious about what's happening to your patients. And there's so much we can gain from that and contribute back to the community of patients.
Sure.
Thank you. I think the messages are very clear in the era that we live in. People are aware about diabetes, but one has to see that there are different types of diabetes, and one need not have a closed mind for these things. Specifically for younger children who have missed insulin, have not led into disasters, there is a point to introspect rather than admonish them. This often happens with the young girls who are about to get married, and Nikhil knows about this so very often. I think it is worth attempting, as happens in subclinical hypothyroidism, that the child or the girl is now getting married. She wants to be getting rid of that stigma which is associated with infertility. And these experiments of types that we have can be cautiously done for people who are with you all the time. But as he said, insulin is the most accepted treatment for these people to begin with. Once they are stabilized, you can decrease the dose, as happens in symptomatic type 2 adult diabetics also, and see what is the outcome. In this regard, you will have some laboratory help through fasting C-peptide after glucose control, antibodies if the patient can afford. In very select situations, you could do more deep panel, but clinical follow-up is going to tell, as my late Professor Dr. Shamsunder, even R.J. Dash used to tell, if the person's insulin requirements are coming down, you're able to taper them off, you don't require any greater proof. And if the person is controlled of beta cell function. So I think clinical this thing, and most importantly, follow-up inquisitiveness are important. Biomarkers are, of course, important. We know that every 2 or 3 years, we get one biomarker. C-peptide it was advent, ascent, and fall. Homocysteine, again, advent, ascent, and fall, because we looked at them wrongly. We look at them as therapeutic targets, whereas they're only markers of the adverse prognosis. If you have got control of LDL with the lowest HRCP, that is still the best kind of a patient for not getting an event. But that doesn't mean that if you reduce HSCRP somehow, that is going to give you the benefit that you have. So all in all, a very good learning experience. And then we had excellent talks on these two non-conventional topics. And what a nice day to have these talks on, then other than the World Diabetes Day. I think Dr. Sangram needs to be congratulated for this. And I thank the audience for their patient hearing and hand over the proceedings.
Thank you, sir. My take-home message is at the end to give a big thank to all of you. I thank Dr. Nikhil Tandon, sir, for sparing your valuable time in spite of his back-to-back programs since from past 3 days in RSS Day, morning, evening, WD, so many meetings. And I also thank Dr. Naik for sparing his Sunday morning, all the way joining from New York to our place, making the event successful. And lastly, I thank Dr. Vipin sparing his continuous 2 hours on this day. I thank once again all the attendees who have joined from all over the country, making it a national event that speaks how much keen they are on this day, Sunday also, because we have got a World Cup final going on. Everybody is keen to watch the match, irrespective of who wins. And I also thank our guest of honor, Dr. P.S. Shankar, Dr. Muruganathan, who did the honors for us. And also thank one and all at the end. Good night. Stay safe. Take care. Bye bye.
Thank you.
Bye, Nikhil. Bye, Sangram. Bye, sir.
Bye.
Bye, Nikhilji.
Bye-bye.